Welcome to the deep dive. Today, we're tackling a really critical and surprisingly common issue. Pulmonary embolism, or PE.
hmm
Think of it as a blockage in the lungs, and we're going to unpack exactly what that means using the expert knowledge found in Rutherford's vascular surgery and endovascular therapy.
And it's a topic that really demands our attention. Pulmonary embolism isn't just some medical term. It's a leading cause of cardiovascular-related deaths globally.
Wow. Leading cause.
Yeah. And what's more, a significant number of people diagnosed with it, well, they don't survive their hospital stay.
That's serious.
It is. But the key insight here isn't just that PE is deadly, but that its often silent nature makes early recognition and action absolutely critical. A delay can have irreversible consequences. And perhaps most importantly, in many cases, it's preventable.
Preventable, that's a powerful word. Okay, so let's get down to basics then. Where do these blockages typically originate? What's the usual starting point?
Well, in the vast majority of situations, the problem begins with a blood clot in the deep veins of the legs, or sometimes the pelvis.
Right.
We call this deep vein thrombosis, or DVT. Basically, a blood clot in a deep vein, most often in the legs.
So a clot forms in the leg and then travels all the way up to the lungs. And it's not just a simple physical obstruction when it gets there, is it? There's more going on.
You're right. It's much more complex. It's really a cascade of events. The physical blockage of the pulmonary arteries, that's just the initial problem.
Okay.
When the lungs detect a lack of blood flow and oxygen, the blood vessels themselves start to narrow. That's called hypoxemic vasoconstriction.
Okay. So the vessels clamp down.
Exactly. Think of it as the lungs' blood vessels clamping down when they don't get enough oxygen. The body also releases these powerful chemicals that further constrict these vessels, significantly increasing the resistance to blood flow in the lungs.
Which puts a huge strain on the heart, specifically the right ventricle, the chamber that pumps blood to the lungs, right?
Well,
So it's like trying to pump water through a clogged pipe, putting extra pressure on the pump itself.
exactly. The increased resistance in the pulmonary arteries means the right ventricle has to work much, much harder.
I see.
And over time, that extra work can cause the right ventricle to weaken and stretch. We call that hypokinesis and dilation.
Yeah.
If this keeps going, it can lead to right ventricular failure.
Which sounds life-threatening.
It is. It's a life-threatening condition where the heart just can't pump enough blood forward, leading to a dangerous drop in blood pressure and overall circulation. And here's another important point. Even if the initial clot breaks down, sometimes it leaves behind scar tissue
Oh, really?
in the vessel walls, and that can lead to chronic pulmonary hypertension, long-term high blood pressure in the lungs, and ongoing problems with the right ventricle.
This paints a picture of a really serious condition with potentially devastating consequences. But what makes PE so difficult to tackle, I gather, is that it doesn't always show itself in a clear or consistent way. It's a bit of a chameleon.
Absolutely. That's a good way to put it. The way PE presents can vary incredibly from person to person. Some individuals might have no noticeable symptoms at all. The clot's only discovered incidentally during tests for something else.
Wow.
Then, on the other end of the spectrum, it can cause sudden death. Whether symptoms develop and how severe they are really depends on the size and location of the clot, and whether the person has any pre-existing heart or lung issues. It's quite sobering to think that PE is estimated to go undiagnosed in a significant number of people who actually survive the initial event. It just highlights how subtle it can be.
So what are the key warning signs then? What are those red flag symptoms that should make someone or their doctor think, could this be PE?
Okay, the most common clues are shortness of breath or dyspnea, chest pain, which can sometimes feel very similar to a heart attack.
Right. Confusing.
Very. Also, pre-syncope or syncope, that sensation of feeling like you're about to faint or actually losing consciousness, and in some cases, coughing up blood or hemoptysis.
And that shortness of breath, does it come on fast?
It can, yeah. It can come on suddenly and be quite severe, especially with larger clots. Smaller clots might cause mild or even fleeting episodes. The chest pain often comes from inflammation of the lining around the lungs. If a smaller clot causes a bit of lung tissue to die off.
I see. And what about the physical signs a doctor might look for during an examination? Beyond what the patient tells them, what might a sharp-eyed doctor pick up on?
Yeah, common findings include rapid breathing or tachypnea, rapid heart rate, tachycardia, unusual sounds when listening to the lungs like crackles or maybe decreased breath sounds in certain areas.
Okay.
Also, swollen veins in the neck, what we call jugular venous distension, and less often a fever. Interestingly, in about half of PE patients, there will also be signs or symptoms of a DVT in the leg. things like swelling, pain, or redness. Sometimes in the arm too, but that's less common.
Right, back to the source.
Exactly. The most critical presentations, though thankfully less frequent, are low blood pressure or hypotension and shock. These usually indicate a large clot blocking a major artery in the lungs or a severely compromised circulatory system. While actually fainting isn't that common, it can happen even without a dramatic drop in blood pressure.
Given this really wide range of how PE can appear, it sounds like nailing down the diagnosis is a real puzzle.
It is indeed. The fact that the symptoms can be so vague and easily mistaken for other things like a heart attack, a tear in the aorta, pneumonia, even a sudden abnormal heart rhythm makes diagnosis really challenging.
So you can't just rely on symptoms.
No, relying on just the clinical picture isn't good enough. That's why doctors have developed these clinical prediction algorithms, essentially scoring systems. They help estimate how likely a PE is based on the patient's symptoms and their risk factors.
Okay, scoring systems. So beyond just looking at symptoms and risk factors, what kind of lab tests can give us more clues?
Well, routine blood tests, the kind you might get during a general checkup, aren't typically very helpful in diagnosing PE specifically.
Not specific enough.
Right. You might see some non-specific changes, but they could point to lots of different things.
Mhm.
However, the high-sensitivity D-dimer assay, that can be very valuable in certain situations.
Okay, the D-dimer, we hear of that one. When is it a useful tool? And when does it maybe not tell us the whole story?
Okay, so a normal D-dimer level, especially when using a high-sensitivity test and adjusting the cutoff based on age for people over 50,
Mm-hmm.
that's really good at ruling out PE in patients where the initial suspicion is low or maybe moderate.
So a negative test is helpful.
Very helpful in those cases. If the D-dimer is negative, it's very unlikely they have a PE. However, a positive D-dimer test is not very specific.
Ah.
It can be elevated for many reasons other than a blood clot, things like infection, inflammation, pregnancy, even just being older. So a positive result always means we need to do more investigation.
Right, doesn't confirm PE, just further looking. What about those heart-related biomarkers, like troponin and BNP? Do they help in figuring out if someone has a PE?
Yes, we can measure blood levels of substances released when the right ventricle is under stress,
Yeah.
like troponin and brain natriuretic peptide, or BNP. Now, while these aren't great for diagnosing PE itself because they're not always elevated and can be up in other heart and lung problems.
Okay, not for diagnosis primarily.
Right. But they do play an important role in assessing the risk in patients who have already been diagnosed with PE, especially those at intermediate risk.
Ah, for prognosis.
Exactly. There are standard cutoff values, but again, adjusting for age with troponin and NT-proBNP, which is a precursor to BNP, gives us a better idea of the risk of a bad outcome. There's also a newer marker called heart-type fatty acid binding protein that looks promising for predicting prognosis in intermediate risk PE.
Interesting. And what about arterial blood gases measuring the oxygen and carbon dioxide levels in the blood? Do they give us diagnostic information?
Arterial blood gases are generally not specific enough to diagnose PE. However, finding low oxygen levels, or hypoxemia, in someone with a confirmed PE can be a sign that the PE is more severe. It might suggest a higher risk of complications or respiratory failure.
Okay.
For patients who seem to be at lower risk, we can often just use a pulse oximeter, that little clip you put on your finger, to non-invasively monitor their oxygen levels.
Right, much simpler. Let's move on to imaging then. What role does an electrocardiogram or ECG play in this diagnostic workup? That's the test that looks at the heart's electrical activity, right?
Exactly. And similar to the lab tests, ECG changes in PE aren't very reliable for diagnosis. They can look similar to changes seen in other conditions that put pressure on the lungs and heart.
Not specific again.
No. The classic pattern you might hear about called S1Q3T3, which suggests acute strain on the right ventricle. Well, it's actually only seen in a minority of PE cases.
So not common.
Not very. The main value of the ECG when we suspect PE is really to help rule out a heart attack as the cause of the patient's symptoms.
Okay, useful for ruling out other things. And a standard chest x-ray. Is that helpful for actually seeing clots in the lungs?
Unfortunately, regular chest x-rays aren't very sensitive or specific for PE either. In fact, many people with a PE will have a completely normal chest x-ray.
Really? Normal.
Yeah. However, a chest x-ray is still important because it can help us exclude other possibilities, like a collapsed lung or pneumonia, things that might cause similar symptoms.
Right.
Now, there are some very rare signs on a chest x-ray things with names like the Fleischner sign, Hampton hump, Westermarck sign, and knuckle sign that should make a doctor think more strongly about PE if they see them, but honestly, they're not common at all.
So if these initial tests aren't usually definitive, what's the sort of go-to imaging? What's the method that really lets you see those clots in the lungs?
That would be computed tomographic pulmonary arteriography, or CTPA.
CTPA.
Think of it as a specialized CT scan that focuses specifically on the blood vessels in your lungs. It's a preferred method because it can visualize the pulmonary arteries, even the smaller branches, with high accuracy.
Okay.
And when we combine the CTPA results with our initial assessment of how likely a PE is based on those scoring systems,
The clinical prediction rules.
exactly, it becomes even more powerful. A major study called PIO-PED-2 showed that CTPA has good sensitivity and specificity for detecting PE. Plus, the CT scan can also give us clues about how the PE is affecting the heart.
How so?
Well, for example, we can measure the size of the right ventricle compared to the left ventricle. If the right ventricle is enlarged, say, a ratio of 0.9 or greater compared to the left, it can indicate that the PE is putting significant strain on the heart. That's important prognostic information.
I see. What about an echocardiogram and an ultrasound of the heart? When might that be used in the diagnostic process for PE?
Good question. Transthoracic echocardiography, or TTE, that's an ultrasound done through the chest wall, is often the first imaging test we'll do to look for signs of right ventricular dysfunction or strain.
Okay.
However, it's important to understand that an echo can't directly see the blood clots in the lungs, so it's not definitive for diagnosing PE.
Right, it sees the effect on the heart, not the clot itself.
Precisely. The right ventricle can be under pressure for other reasons besides a PE. Where echocardiography really shines is in assessing the severity and prognosis of a confirmed PE.
Ah, okay, so after diagnosis or maybe alongside?
Yes. If an echo shows that the right ventricle isn't functioning well, it's a strong indicator of higher risk. It at least doubles the chance of death.
Wow, doubles. So what specific things might an echocardiogram show that would make you suspect right ventricular trouble in the context of a possible PE?
Well, there are several things we look for. One is the size of the right ventricle compared to the left. If the RV is significantly larger, that's a concern.
Figure RV, okay.
We also measure something called tricuspid annular plane systolic excursion, or TPSE. This basically measures how much the tricuspid valve moves up and down when the heart contracts.
How well it's pumping.
Kind of, yeah. A TAP PSE of 1.6 centimeters or less suggests the right ventricle isn't pumping strongly enough. Another sign is the McConnell sign, where the middle part of the right ventricle's outer wall doesn't contract well, but the very tip, the apex, still does. It's a specific pattern.
It's an interesting pattern.
And in rare cases, we might actually see the blood clot within the right ventricle itself. Well, we don't routinely recommend an echo for every suspected PE unless the patient is very unstable.
Right.
If we do find signs of right ventricular dysfunction on an echo, and maybe we can't get a CTPA right away, that might be enough evidence to start emergency treatment for PE.
Makes sense in urgent situations. Are there any other imaging techniques that doctors might use to diagnose PE, maybe in specific circumstances?
Yes, there are a few less common options. Ventilation perfusion, or VQ, scans are rarely used these days.
PQ scans.
Yeah, primarily maybe in pregnant women or people with kidney problems, where a CTPA with contrast dye might not be the best choice. VQ scans are very good at detecting a mismatch between airflow, ventilation, and blood flow perfusion in the lungs, which could be a sign of PE, but they're not very specific. Other lung conditions can also cause these mismatches.
Okay, anything else?
There's magnetic resonance, pulmonary angiography, or MRPA. It's another alternative if a VQ scan isn't clear and a CTPA can't be done, but it's a more complex test. The image quality isn't always as good as CTPA, and it's generally not as sensitive.
So limited use.
Pretty limited.
Yeah.
And then there's invasive pulmonary angiography. This used to be the gold standard for diagnosis, injecting dye directly into the pulmonary arteries.
The old way.
Right. Now we mostly reserve it for situations where we're actually planning to do a catheter-based treatment to remove the clot at the same time.
Got it. What about trying to find the original source of the clot? Is an ultrasound of the legs helpful in diagnosing a PE?
Absolutely. A lower extremity venous duplex ultrasound, which is an ultrasound of the veins in the legs, can detect a DVT in about 30 to 50% of patients who have a PE.
So a decent percentage.
Yeah. And if we find a DVT in one of the larger veins above the knee, a proximal DVT in someone we suspect has a PE, that's often considered enough to just start treatment with blood thinners.
Without even needing the CTPA necessarily.
Sometimes, yes. If the clinical suspicion for PE is high, and we find a proximal DVT, many guidelines say you can start treatment. Interestingly, patients who have a symptomatic PE and also have a confirmed DVT seem to have a higher risk of short-term mortality compared to those with a PE, but no detectable DVT.
That's important. So putting it all together then, what's the typical approach doctors take when someone comes in and they suspect a PE? What's the overall strategy for diagnosis?
Okay, so for patients who are breathing okay and have stable blood pressure, what we call hemodynamically stable, and aren't pregnant, we often start with those clinical prediction rules we talked about,
The Wells score or Geneva score?
right? Like the Wells score or the modified Geneva score. These help us estimate the pretest probability of PE based on their symptoms and risk factors.
Yeah.
Then, depending on their score, we'll often check a D-dimer level.
Okay.
The results of the prediction rule and the D-dimer level help us decide if a CTPA is the next logical step, if the pretest probability is high, or if it's low to moderate, but the D-dimer is elevated.
Then you do the CTPA.
Then we'll usually proceed with a CTPA. If the CTPA is negative, we typically don't need to do any more tests for PE. If it's positive, well, we start treatment with anticoagulation.
And if the probability is low and the D-dimer is normal?
In patients with a low pretest probability and a normal D-dimer, PE is pretty much ruled out. No further testing usually needed.
Okay, that makes sense. So figured out if someone has a PE. The next really important step is understanding how serious it is, right? We need to assess the risk involved.
Exactly. Risk stratification is crucial. Our main focus here should be on determining the patient's risk of dying early, in the short term, because of the PE, not just how big the clot is or how many vessels are blocked.
So it's about the impact more than the size.
Precisely. While it might seem logical to classify PE based on the extent of the blockage seen on imaging, that doesn't always correlate well with the risk of death, especially since other underlying health problems can significantly impact the outcome. But accurately assessing risk is absolutely essential for guiding our treatment decisions.
So how do doctors typically categorize the risk associated with the PE? What are the main buckets?
We generally divide PE risk into three main categories:
Hmm.
low, intermediate, sometimes also called submassive and high, or massive risk.
Low, intermediate, high. Got it.
And these categories are based on the estimated probability of death within the next 30 days. It's important to remember that the terms submassive and massive aren't primarily about how much of the lung's blood supply is blocked on an angiogram anymore. It's more about the hemodynamic impact and risk of death.
Okay, that's a key distinction. Can you break down what defines each of these risk categories in a bit more detail?
Certainly. Low-risk PE includes patients who have normal blood pressure, no signs of right ventricular strain on imaging like CT or echo, and normal cardiac biomarkers like troponin and BNP.
Everything looks okay hemodynamically?
Pretty much. About 40% of PE patients fall into this group, and they generally have a very good short-term outlook. The mortality rate is around 1% to 2%, maybe even lower.
That's good. What about intermediate?
Intermediate risk PE includes patients who also have normal blood pressure, but they show either evidence of right ventricular dysfunction on imaging, or they have elevated cardiac biomarkers, or sometimes both.
So stable blood pressure, but signs of heart strain.
Exactly. This is actually the largest category, making up about 55% of cases. Their mortality risk is more significant, ranging from about 3% up to 15%.
Okay, a wider range there. And high risk.
High-risk PE involves patients who are hemodynamically unstable. That means they have persistently low blood pressure systolic, below 90 mmHg, or they've suffered a cardiac arrest.
The sickest patients.
Yes, this is the rarest group, around 5% of PE cases, but they face a very high in-hospital mortality rate, ranging from 15% to 30%, and potentially exceeding 60% for those who needed CPR.
Extremely high risk. Are there specific scoring systems that help doctors with this risk assessment beyond just blood pressure and biomarkers?
Yes, several scoring systems have been developed to help us quantify this risk. The most commonly used are the Pulmonary Embolism Severity Index,
Right.
or PC, and its simplified version, the SPACY.
PC and SPECY.
Right. There are also others like the BOVA and FAST scores, which are specifically used for patients who aren't hemodynamically unstable, to help stratify that intermediate group.
Okay.
Combining the information from these scores with what we see on imaging, the RV size on CT or echo, and the lab results, those biomarkers, helps us get a more accurate picture of the risk. No single factor is perfect on its own.
Makes sense. It's a combination of factors.
Exactly. And within that intermediate risk group, we often do further assessment, focusing specifically on how the right ventricle is functioning and the levels of those cardiac biomarkers. The European Society of Cardiology has even divided the intermediate risk group into intermediate low and intermediate high risk.
Getting more granular.
The intermediate high group typically includes patients who have both imaging evidence of RV dysfunction and elevated cardiac biomarkers. They're closer to the high-risk end of that spectrum.
Okay, so we've diagnosed the PE, we've figured out the risk level. Now let's talk about what we actually do about it, the treatment. What's the main goal of treating a PE?
Well, the immediate and primary goal is simple: prevent death.
Stop the patient from dying from this acute event.
Exactly. Beyond that, researchers are looking into whether more aggressive initial treatments, like using those powerful clot-dissolving drugs, thrombolytics, might help prevent long-term complications.
Like that chronic hypertension you mentioned earlier.
Right, like chronic thromboembolic pulmonary hypertension, or CTEP, and maybe improve a patient's long-term functional capacity. But honestly, that's still an area of active investigation. The main focus initially is survival.
Understood. So for those patients who are at higher risk, intermediate, or high size, what are the first supportive steps that doctors will take even before specific clot treatment?
For these patients, initial management involves carefully assessing their vital signs and providing general support, especially if they're unstable or kind of borderline. If a patient has low blood pressure, we might give intravenous fluids,
Fluids, okay.
but we have to be cautious. We often start with small amounts, like 500 milliliters, because giving too much fluid can actually worsen the strain on the already struggling right ventricle.
Okay. Cautious fluids.
Right. If fluids aren't enough to raise the blood pressure, then we might use vasopressor medications, like norepinephrine is often the first choice, to help support blood pressure and maintain adequate blood flow to the vital organs, especially in cases of severe shock.
Got it. And then there's anticoagulation blood thinners, which I understand is a really fundamental part of treating pretty much all PEs.
That's absolutely right. Anticoagulation is the cornerstone. Unless there's a very specific reason why a patient absolutely cannot receive them, a major contraindication, all patients diagnosed with acute PE should be started on systemic anticoagulation as quickly as possible.
Why so urgently?
The goal is twofold: prevent an immediate death from the existing clot getting worse or moving, and prevent the development of more blood clots. Ideally, we want to start anticoagulation even while we're still in the process of confirming the PE diagnosis in patients where we have a moderate or high suspicion.
Start it even before the CT scan, maybe.
If the suspicion is high enough, yes. The usual duration of treatment is at least 3 months, sometimes longer depending on the circumstances.
And how is it given initially?
In the initial acute phase, we typically use injectable blood thinners. Options include unfractionated heparin, often given as an IV drip, low molecular weight heparin, like enoxaparin, given as shots under the skin, or fondaparinux, another injection.
Okay, injectables first.
Often, yes. If we're planning to transition to warfarin, which is a vitamin K antagonist taken by mouth, we'll usually start at the same time as the injectable. We continue both for several days until the warfarin level gets into the therapeutic range that's called bridging.
Right, the overlap period.
Exactly. But now, direct oral anticoagulants, or DOACs, have become increasingly popular. Things like rivaroxaban, apixaban, dabigatran, edoxaban.
Newer ones.
Yes. They're often just as effective, maybe even safer in some ways, and they have the big advantage of not requiring routine blood monitoring or that initial bridging period with injectables for most of them. You can often start them directly or after a very short course of parenteral anticoagulation.
Simpler for the patient.
Generally, yes. What about an IDC filter, that little metal cage device placed in the main vein coming from the lower body of the inferior vena cava? When might that be considered? An IVC filter is generally considered in a couple of specific situations. First, in patients with an acute PE who have an absolute contraindication to blood thinners, meaning they absolutely cannot take them, perhaps due to active major bleeding.
Okay, can't use thinners.
Right. Or in those rare cases where someone continues to have recurrent PEs despite being on adequate anticoagulation therapy.
Filter if thinners fail or can't be used?
Essentially, yes.
Yeah.
Current medical guidelines generally do not recommend routinely placing IVC filters in patients who can be safely treated with blood thinners. There's not good evidence it helps, and it can have its own complications.
So not for everyone.
Definitely not. However, there's still some debate about whether they might offer some additional benefit in anticoagulated patients who have a very severe PE, like those with dangerously low blood pressure or massive clots. But that's not standard practice based on current guidelines.
Okay. Let's talk about thrombolysis, those powerful clot-busting drugs. You mentioned them earlier. When are they actually used in the treatment of PE?
Right, thrombolysis.
Yeah.
This is reserved primarily for patients with high-risk PE, the ones who are hemodynamically unstable.
The sickest group.
Yes. And also, in some carefully selected situations, for patients with intermediate-risk PE who appear to be deteriorating or have very severe RV dysfunction.
Okay, high risk, selected intermediate risk. How quickly do they need to be given?
These drugs work best when given early, ideally within 48 hours of when the symptoms started. But they can still potentially be beneficial up to 14 days out in some cases.
And how are they administered?
Well, thrombolytics can be administered through a standard intravenous line, just into a vein in the arm that's systemic thrombolysis. But there's also a growing trend towards using catheter-directed administration,
Catheter-directed, meaning?
meaning a catheter is guided up into the pulmonary arteries right near the clot, and the drug is infused directly there.
Ah, targeted delivery.
Exactly. The reasons why someone might not be a candidate for thrombolysis in PE, the contraindications are largely based on what we know about the risks of bleeding from using these drugs in patients having heart attacks. Yeah, we kind of extrapolate that data.
Okay. Can you explain a bit more about these different ways of giving thrombolytics? Systemic versus catheter-directed.
Sure. Systemic intravenous thrombolysis, where the drug is given through a vein in the arm, is generally recommended, really universally recommended, for patients with high-risk PE, the unstable ones.
Okay, standard for high risk.
Yes. For intermediate-risk PE, the decision is much more complex and controversial. The standard drug used often is alteplase, or TPA, usually given as an infusion over a couple of hours. Other thrombolytic drugs have also been studied, like ritaplase, tenecteplase.
And the controversy for intermediate risk is?
It's about balancing benefit and risk. Some large studies and meta-analyses have suggested that using thrombolytics in intermediate-risk PE might reduce the risk of death or hemodynamic collapse compared to just using blood thinners alone.
That sounds good.
But it also clearly increases the risk of major bleeding, including potentially fatal bleeding inside the brain, especially in older individuals.
Ah, the downside. Bleeding risks.
Exactly. There's some evidence now suggesting that maybe using lower doses of thrombolytics, sometimes called half-dose regimens, might be just as effective and potentially safer, but we need more robust data on that. It's interesting to note that despite the potential benefits in very sick, unstable patients, systemic thrombolysis is sometimes underused.
Why is that?
Probably partly due to those concerns about bleeding risks and maybe sometimes uncertainty about the contraindications.
Okay. You also mentioned catheter-directed interventions, CDIs. How are those different from just giving the thrombolytic drug systemically?
Right, CDIs are a more localized approach. Instead of circulating the clot-busting drug throughout the whole body, we use a thin tube, a catheter, that's guided through the blood vessels directly to the location of the clot in the pulmonary arteries.
Right up to the clot.
Exactly. This allows us to deliver the thrombolytic drug directly onto the clot, often in much lower total doses than we would use systemically. And sometimes these CDIs also involve mechanical methods to actually break up or physically remove the clot, either on their own or in combination with the thrombolytic drug.
So, potentially less bleeding risk because it's local and lower dose?
That's the hope and the rationale behind it. While early studies have shown promise, particularly in improving RV function quickly in intermediate-risk patients, we still need more strong evidence, especially comparing CDI head-to-head with systemic therapy or anticoagulation alone, particularly for high-risk PE, to really understand the impact on major outcomes like mortality and bleeding in the long run.
So, still evolving. What are some of the specific techniques used in these catheter-directed interventions?
There's quite a range of techniques now. Some focus purely on mechanical removal or fragmentation of the clot without using any thrombolytic drugs at all.
Physical removal.
Yes. This might be an option for patients who absolutely cannot receive thrombolytics due to very high bleeding risk. These non-thrombolytic mechanical methods, like aspiration thrombectomy, are showing increasing evidence of being effective and safe.
Okay. And when thrombolytics are used with catheters?
When thrombolytics are used in CDIs, they're often delivered slowly through catheters that have multiple tiny side holes near the tip. This allows the drug to kind of bathe the clot directly over several hours.
Slow infusion right at the site.
Exactly. Ultrasound-assisted thrombolysis, or USA, is a specific type of CDI. It uses a special catheter that emits low-power ultrasound waves. The idea is that the ultrasound helps the thrombolytic drug penetrate deeper into the clot and work more effectively. There's good evidence supporting USX, particularly from the Ultima trial, showing it improves RV function faster in intermediate-risk PE compared to just anticoagulation, although the difference wasn't maintained long-term in that specific study.
Ultrasound helps the drug work better.
That's the theory. Because we're delivering the drug directly, we can often use lower total doses of the thrombolytic and shorter treatment times compared to systemic infusion. And doing the lysis procedure, we also typically give a continuous infusion of heparin, a standard blood thinner, through the catheter or intravenously.
And what about those purely mechanical techniques you mentioned? How do they actually work to get the clot out?
Right, mechanical approaches. These involve physically disrupting or removing the clot. Older techniques sometimes use specialized catheters with a rotating pigtail tip or inflatable balloons to try and break up the clot, but this could sometimes cause smaller pieces to travel further downstream into the lungs, which isn't ideal. So that might be combined with suction.
Fragmentation risk.
Yes. More modern approaches focus on aspiration, sucking the clot out. There are dedicated large-bore aspiration catheters designed specifically for this purpose, and we now have specific devices that are FDA-approved for PE thrombectomy. Two main ones are the FlowTriever system and the Indigo-C AST system. The FlowTriever uses expandable nitinol discs on catheters to engage and pull the clot out, often combined with aspiration through a large sheath.
Crabs and poles.
Kind of, yeah. The Indigo-C AST system uses continuous suction through different size catheters, often along with a special separator wire that helps break up the clot as it's being sucked out, making aspiration easier.
Suction plus disruption.
Right. There's another device, the Angiovac system, which uses a very large suction catheter connected to a filtration circuit outside the body, kind of like a bypass circuit. It can remove large amounts of clot, but its use specifically in PE has been somewhat challenging due to the difficulty in positioning that large cannula effectively and safely within the pulmonary arteries.
I see. So mostly CloTriever and Indigo-C CAF for mechanical removal right now.
Those are the most commonly used purpose-built devices currently, yes.
Now, in really critical situations, when someone has a massive PE, maybe these catheter things aren't enough or aren't possible. Is surgery ever an option to physically remove the blood clot? Open heart surgery.
Yes, surgical thrombectomy or pulmonary embolectomy is typically reserved for patients with a confirmed large clot in the main pulmonary arteries who are in profound shock, meaning very low blood pressure, despite all other efforts, and crucially, who either can't receive thrombolytics due to contraindications or who have failed to improve after receiving thrombolytics.
So a rescue option often.
Often, yes, or sometimes as a primary therapy in very specific centers for patients deemed too unstable for anything else. The goal is to immediately and dramatically reduce the pressure on the right ventricle by surgically opening the pulmonary artery and removing the large clots.
How risky is that?
It's major surgery, so it carries significant risk. However, outcomes have improved significantly in specialized centers with experience in this procedure. The risk of death is generally higher if the surgery is done after a failed attempt at thrombolysis, or especially after the patient has had a cardiac arrest.
Mhm.
The best outcomes are usually seen when surgery is chosen as the first-line treatment in these very severe select cases.
How is it done?
The procedure usually involves opening the chest through a median sternotomy, like for standard heart surgery, and using a heart-lung machine, cardiopulmonary bypass, to support the patient's circulation while the surgeon removes the clots from the main pulmonary arteries. Often, they can do this without stopping the heart completely.
Okay, a major intervention for the worst cases. And in the absolute most critical scenarios, maybe someone is crashing even before surgery or thrombolysis can happen, where the patient's heart and lungs are really failing. What other advanced life support measures might be considered?
In those truly dire situations, extracorporeal membrane oxygenation, or ECMO, can provide temporary support for both the heart and lungs.
ECMO, like an artificial lung and heart.
Essentially, yes. It takes blood out of the body, oxygenates it, removes CO2, and pumps it back in, bypassing the patient's failing heart and lungs. It acts as a bridge buying time to allow more definitive treatments like thrombolysis, catheter intervention, or surgery to work, or simply time for the patient's own heart and lungs to recover somewhat.
So a bridge to treatment or recovery?
Exactly. ECMO is being used more and more in certain specialized centers for very unstable PE patients who aren't responding to standard therapies, or sometimes as a way to stabilize them before attempting a catheter-based or surgical clot removal procedure. However, we don't yet have really clear guidelines or strong predictive factors to know exactly which specific patients are most likely to benefit from ECMO in the context of PE. It's still evolving.
A lot of complex options for severe PE. It sounds like the initial treatment often happens in the hospital, especially for intermediate and high-risk patients. But what about the possibility of sending some patients home early, maybe even treating them entirely as outpatients? Is that ever safe?
Yes, absolutely. Early discharge, and in some cases even home treatment from the beginning, can be a safe and effective approach for carefully selected low-risk PE patients.
Low risk only.
Yes, they have to meet very specific criteria. We often use those clinical probability scores, particularly the PZ score or the SPECI, to help identify these individuals. A score of 0 on the SPECI, for instance, puts them in a very low-risk category.
What else qualifies them for early discharge?
Important factors include stable vital signs, good blood pressure, heart rate, breathing rate, not needing supplemental oxygen, having no significant risk factors for bleeding, no serious coexisting medical conditions like severe kidney or liver disease or recent stroke, and importantly, having adequate support at home. That includes the mental capacity to understand and stick to the treatment plan and having someone reliable available if needed.
Social support matters too.
Definitely. While the value of routinely checking cardiac biomarkers like troponin or doing an echocardiogram just to rule out any subtle right ventricular dysfunction before considering early discharge is still being investigated,
Mm.
while there are certain absolute requirements, like those I mentioned, that must be met before sending someone home early with a PE diagnosis is even considered.
Okay. So, to summarize the treatment strategies, then, it really comes down to how sick the patient is initially, their hemodynamic status, and then their overall risk profile based on RV function and biomarkers, doesn't it?
Precisely. The patient's hemodynamic status, whether they have stable blood pressure and circulation or not, is the most critical factor in the immediate short term. We essentially categorize patients as stable or unstable.
Unstable versus stable.
Right. Unstable patients often need immediate interventions to restore blood flow, with systemic thrombolysis often being the first consideration if there are no contraindications. Stable patients are then further assessed based on their risk of developing complications using those scores, imaging, and labs.
And for the intermediate risk group.
For those stable patients who fall into the intermediate risk category, we need to carefully weigh the potential benefits and risks of more aggressive therapies beyond just standard anticoagulation. Who might benefit from thrombolysis or maybe a catheter intervention?
Complex decisions.
They can be. And because these decisions can be complex, time-sensitive, and often require input from different specialists, many hospitals have developed pulmonary embolism response teams, or PERTs.
PERTs.
Yes, PERTs. These teams typically bring together experts from different fields like cardiology, pulmonology, critical care, interventional radiology, sometimes cardiac surgery, hematology, to rapidly evaluate intermediate and high-risk PE patients. They discuss the case, develop a coordinated consensus treatment plan, and help mobilize the necessary resources quickly.
A multidisciplinary rapid response.
Exactly. The goal is to expedite and optimize care for these sicker PE patients.
Makes a lot of sense. Let's switch gears now and talk about some specific groups of people or situations where PE might present differently or require special consideration. For example, what if a small blood clot in the lungs is found unexpectedly, like incidentally, when someone is having a scan for something else entirely?
Right. Incidental subsegmental pulmonary embolism. This means a small clot, usually in one of the smaller outer branches of the pulmonary arteries, found on chest CT done for a reason other than suspected PE, often in someone who doesn't have typical PE symptoms. This presents a tricky situation.
Tricky how?
Well, we're often not sure how clinically significant these very small, isolated clots are. Do they carry the same risks as larger PEs?
Yeah.
And so the best way to manage them is still debated. There isn't universal agreement.
So, treat with blood thinners or not?
That's the question. Factors that might lean towards starting anticoagulation include the presence of other risk factors for blood clots, like recent surgery, immobility, if the person is hospitalized or has very limited mobility, if they have active cancer, if their underlying heart and lungs aren't very healthy, low cardiopulmonary reserve, or even if they do have some subtle symptoms like unexplained shortness of breath or pleuritic chest pain.
Reasons to treat.
Yes. On the other hand, if the patient has a very high risk of bleeding, that would argue strongly against using blood thinners for such a small incidental finding. It's often a case-by-case decision, weighing the potential risks and benefits.
Okay, what about a really dramatic situation where a blood clot is actually seen moving, like floating, within the heart itself? That sounds incredibly serious.
Thrombus in transit, or a floating right heart thrombus, is indeed a rare but very dangerous finding. You might see it on an echocardiogram. It's often associated with a large or massive PE and carries a very high immediate risk of death because that clot can break off and completely obstruct the pulmonary
It's
outflow.
extremely high risk.
Yes, we don't have specific guidelines for exactly how to manage it. Outcomes can vary whether you use just blood thinners, give clot-busting drugs, or try some kind of mechanical removal. If the patient also happens to have a patent foramen ovale, a small hole between the upper chambers of the heart, the atria,
A PFO.
right. If they have a PFO, there's a risk the clot could cross over to the left side of the heart and cause a stroke. In that specific situation, surgical removal of the clot is often preferred, if possible.
Wow. PE during pregnancy is also a significant concern, I understand. That must be very complex to manage.
Yes, PE is unfortunately a leading cause of pregnancy-related deaths in mothers, particularly in developed countries. The risk is actually highest in the period after delivery, the postpartum period, especially following a cesarean section.
Higher risk after delivery.
Yes. During pregnancy itself, shortness of breath is a very common complaint, so it needs to be carefully evaluated to make sure it's not PE. The usual scoring systems we use to predict PE haven't been well studied or validated in pregnant women.
So harder to assess probability.
A bit, yes. And D-dimer levels normally increase quite a bit during pregnancy, making the test less specific. However, we still often use the standard cutoff values. A negative test is still somewhat reassuring, but a positive one is very common and doesn't mean much on its own.
So if D-dimer is positive, then what?
If the suspicion remains, we'll often start with an ultrasound of the leg veins to look for a DVT. If that's negative, we might need to proceed to imaging of the chest. CT angiography, CTPA, can be done, and the radiation risk to the fetus is actually quite low, especially with modern protocols. Sometimes a lung scan, a VQ scan, might be preferred as it may have slightly lower radiation dose to the mother's breast tissue.
And treatment during pregnancy.
Low molecular weight heparin, LMWH injections are the anticoagulant of choice during pregnancy. Warfarin is generally avoided due to risks to the fetus, and we don't have enough safety data on the DOACs yet.
LMWH is the standard.
Yes. For the rare cases of high-risk PE in pregnancy requiring thrombolytics, the rates of complications for the mother seem to be similar to non-pregnant women. But of course, there are risks to consider. Catheter-based treatments show promise, but we really need more data. Thrombolytics are generally avoided right around the time of delivery due to bleeding risk. In that situation, surgical or catheter-based mechanical thrombectomy might be better options if urgent treatment is needed.
Very challenging situation. And what about people who have cancer? We know they have a higher risk of developing blood clots in general. How does that affect PE management?
That's correct. Venous thromboembolism, both DVT and PE, is much more common in cancer patients, especially those actively undergoing chemotherapy. Having cancer is also an independent risk factor for having a worse outcome if a PE does occur, higher mortality and recurrence rates.
So higher risk population, how is treatment different?
For many years, low molecular weight heparin, LMWH, given as daily injections, was considered the first-line treatment for cancer-associated thrombosis, often for at least 3 to 6 months, and sometimes for as long as the cancer remains active or treatment continues.
LMWH again?
Yes. However, more recently, several studies have shown that certain direct oral anticoagulants, specifically edoxaban and rivaroxaban, can be effective alternatives to LMWH in many cancer patients. Apixaban is also increasingly used. The choice between LMWH and a DOAC often depends on the type of cancer, especially gastrointestinal cancers, which might have higher bleeding risk with DOACs, potential drug interactions with chemotherapy, and patient preference.
DOACs are an option now too.
Yes, becoming more common. Long-term anticoagulation, often beyond the initial 3–6 months, is frequently considered in cancer patients due to their persistently higher risk of the PE coming back. However, in patients who have a very high risk of bleeding, or perhaps after a PE provoked by surgery for the cancer, or in those who seem to have a lower risk of recurrence based on their cancer status, stopping the blood thinners earlier might be considered. It's an individualized decision.
Okay. Finally, before we move to prognosis, what about pulmonary embolisms that aren't actually caused by blood clots? Are there other things that can block the pulmonary arteries?
Yes, absolutely. Non-thrombotic pulmonary embolism refers to the blockage or embolization in the pulmonary arteries caused by something other than a blood clot. This can include things like fat, amniotic fluid, tumor cells, clumps of bacteria, septic emboli, air, or even foreign materials like pieces of catheters or cement from procedures.
A whole range of things. How are they diagnosed?
Diagnosing these can be really challenging. It often relies on a high level of clinical suspicion based on the context, like a recent long bone fracture for fat embolism, or recent delivery for amniotic fluid embolism combined with specific findings on imaging, if available.
Can you give a quick rundown of the main types?
Sure. Fat embolism typically occurs after a major long bone fracture or orthopedic surgery. Patients might develop a classic triad of breathing problems, confusion or altered mental status, and a specific type of pinpoint rash called petechiae. Treatment is mainly supportive.
Okay.
Amniotic fluid embolism is a very rare but often catastrophic complication that can happen during or shortly after childbirth. It causes sudden severe hypoxia, low blood pressure, and problems with blood clotting, coagulopathy. Management is again primarily supportive and often unsuccessful. Yes. Tumor cell embolization, where clumps of cancer cells travel to the lungs, is actually rarely diagnosed before death. Treatment would focus on the underlying cancer. Septic embolism usually comes from infections elsewhere, often right-sided endocarditis, infection of heart valves, or infected 5E lines or devices. It typically manifests as sepsis with respiratory distress and often multiple spots on lung imaging. Treatment focuses on antibiotics and dealing with the source of infection.
Infection spreading to the lungs.
Essentially, air embolism is usually iatrogenic, meaning caused by a medical procedure like central line placement or removal or certain surgeries. Supportive measures include giving high-flow oxygen, trying to position the patient on their left side, and sometimes hyperbaric oxygen therapy.
Okay.
And finally, pulmonary embolization of foreign materials is becoming more recognized, perhaps more common, with the increasing use of endovascular interventions and devices. If a piece of catheter, coil, or cement breaks off and travels to the lungs, the recommendation is usually to retrieve it, often using catheter-based techniques.
Lots of possibilities beyond just blood clots. So, thinking about the more common blood clot PE, after someone has had one and received treatment, what's the long-term outlook? What's the prognosis like?
Well, the long-term outlook after an acute PE really varies quite widely. It depends heavily on the severity of the initial blockage and, crucially, how much it affected the right ventricle. Right ventricular failure is the most common cause of death in the early stages of PE.
RV function is key.
Absolutely. Even in patients who seem hemodynamically stable initially, if there's evidence of strain on the right ventricle shown on echo or CT, or by elevated biomarkers, they generally tend to have worse long-term outcomes and higher mortality compared to those without RV strain. Patients who don't show any signs of right ventricular dysfunction usually have a very low risk of death from the PE itself, less than 2%.
That's reassuring for the low-risk group.
It is. Thankfully, treatments like prompt anticoagulation and, in severe cases, reperfusion therapies like thrombolysis or embolectomy have significantly improved survival rates over the years. For those who do survive the initial PE event later on, mortality is often related to other underlying health issues like cardiovascular risk factors or the presence of cancer. But we also always have to consider the possibility of the PE recurring or the late development of CTEP.
And recurrence of PE, that is a real concern for some patients, isn't it? How common is it?
Yes, PE can definitely recur, and it's not infrequent. The risk is higher in patients with persistent risk factors, particularly active cancer, or in those whose initial PE didn't have a clear temporary provoking cause, what we call unprovoked PE.
Unprovoked PE has higher recurrence risk.
Generally, yes. In these situations, doctors might consider recommending long-term, sometimes even indefinite anticoagulation to prevent recurrence. If a PE happens while someone is already taking blood thinners, it often suggests that the dose wasn't adequate or they weren't taking it correctly, subtherapeutic levels. The decision to stop anticoagulants after the initial treatment period, usually 3 to 6 months, is always a balancing act. We have to weigh the patient's estimated risk of having another PE against the ongoing risk of bleeding from the anticoagulant medication, as well as the cost and inconvenience of being on long-term treatment.
Risk versus benefit calculation.
Exactly. Even after stopping a standard course of anticoagulation, the risk of a late recurrence over the following years can still be significant, maybe 5–10% or more in some groups. Interestingly, some recent research suggests that even those very small subsegmental PEs found way out in the periphery of the lungs might have a similar risk of recurrence as larger, more central clots, although this finding is still being debated.
Still learning about those smaller clots. You've mentioned chronic thromboembolic pulmonary hypertension, or CTEP, a couple of times now as a long-term complication. Can you explain again how that develops after someone has had a PE?
Sure. CTEP usually develops as a long-term consequence of one or sometimes multiple previous PEs. Importantly, those earlier PEs might not even have been diagnosed at the time they occurred.
So it can happen after unnoticed PEs.
Yes. What happens is, over time, the blood clot that initially blocked the pulmonary artery doesn't completely dissolve. Instead, it undergoes a process of organization and remodeling, basically turning into fibrous, scar-like tissue that becomes incorporated into the vessel wall.
Scar tissue in the artery.
Right. This leads to permanent narrowing and stiffening of the pulmonary blood vessels. If this process affects enough of the pulmonary circulation, it can result in persistently high blood pressure in the lungs. We define CTEP as having a mean pulmonary artery pressure above a certain level, usually 20 or 25 millimole Hg, that lasts for more than 3 to 6 months after the initial PE event, despite adequate anticoagulation.
And what are the symptoms?
In the early stages, someone with CTEP might not have any noticeable symptoms. But as the pulmonary hypertension progresses, it typically leads to increasing shortness of breath, especially with exertion, fatigue, and difficulty exercising. Eventually, it can lead to right heart failure.
How common is it after a PE?
It's estimated to occur in perhaps 2 to 4% of people after a symptomatic acute PE, although the exact number is debated. It typically develops within the first couple of years after the PE. There's some limited, controversial evidence suggesting that using thrombolytics to treat the initial acute PE might potentially reduce the risk of developing CTEP later on, but that's not proven.
So should people be screened for it after a TE?
Because CTEP is treatable, often with surgery or specific medications, screening is important. We generally recommend that patients who have had a PE undergo an echocardiogram about 3 to 6 months after the event to check for any signs of persistent pulmonary hypertension or right ventricular dysfunction. If the echo is abnormal, further investigation is warranted.
Okay, follow-up echo is key. This has been an incredibly comprehensive and really insightful deep dive into pulmonary embolism. Hugely complex topic. To wrap up, what are the most important things you'd like our listeners to take away from this discussion?
Yeah, it is complex. I think the key messages are that PE is a serious, potentially life-threatening medical condition that requires prompt diagnosis and careful assessment of risk. That risk stratification is absolutely vital to guide the most appropriate treatment for each individual.
Right. Tailoring the treatment.
Exactly. We've made significant progress, really, in both our ability to diagnose PE quickly and accurately with tools like CTPA and D-dimer, and in the range of treatment options available. We have effective anticoagulants, including the newer DOACs. We have powerful clot-dissolving drugs for severe cases, and increasingly sophisticated catheter-based interventions alongside surgical options for select patients.
Lots of tools in the toolbox now.
We do. But it's vital to remember that the best approach to managing PE always involves carefully considering each patient's individual circumstances, their hemodynamic status, their underlying health, their bleeding risk, and their specific risk factors for recurrence.
Personalized medicine in action. And a final thought perhaps for you, our listeners, to ponder after this deep dive.
Well, I'd say that while we've learned a great deal about pulmonary embolism and have developed these increasingly sophisticated ways to diagnose and treat it, the field is still evolving. Ongoing research continues to refine our strategies, like optimizing the use of thrombolytics, understanding the long-term effects better, figuring out who needs extended anticoagulation, and improving the outcomes for CTEP. The ultimate goal is always to improve the long-term survival and quality of life for those affected by this condition. So if you have any specific concerns about PE or risk factors, please don't hesitate to look into the resources we've discussed based on Rutherford's, or more importantly, reach out to a healthcare professional for personalized advice.